morning. Thank you very much for the opportunity to present our work today. This work was funded by a fellowship supported by BASC, in particular from the Revision E working group. So I worked with the Universities of Exeter and Oxford to produce this work in conjunction with the help with the NJR. So revision knee replacement represents a complex umbrella of procedures, different to primary knee replacements. They're complex, they've got higher re-revision rates, they've got higher complication rate profile, they're expensive, and they've also got worse problems. So what we also know is that with each re-revision or each subsequent re-revision procedure, the rates of PJI increases and worsens. We know that compared to some common types of cancers such as melanoma, breast cancer, prostate cancer, actually PJI has a very similar 5-year mortality. So it's really important that we get this right the first time, or in the context of a primary knee replacement, getting the revision right, or getting it right the second time. So in 2015 there was a report led by Professor Briggs that looked into the practice of revision knee replacement amongst other adult elective orthopedic services, and what they found is that in revision knee replacement, also revision hip, in a relatively low volume, high complex work, that actually there's a very high rate of low volume surgery. They found up to 80% of surgeons performing fewer than 10 revisions a year. So in response to this, the British Association of Surgery of the Knee, led by Professor Andy Toms and Mr. Andy Porteous and Prof Price, they came up with the principle of revision knee networks, as we're all very aware of. And these are based on the same principles as the cancer and trauma networks, whereby the high volume centre in each region coordinates the care, and they identify the complex cases and ensures that these cases are done by the most appropriate centre or surgeon. And the way that this came about is that there's some evidence outside of revision knee replacement that suggests that higher volume surgeons and units get better results. And the current thresholds that are set is that if you're a surgeon, you should be performing at least 15 revisions a year, and that's based on 36-month MGR data. And if you're a major revision centre, so you're that sort of highly specialised unit coordinating practice, you should be aiming at more than 50 a year. And if you're a unit otherwise performing revision surgery to ensure that you're providing the best outcomes for your patients, that threshold is set at 30 a year. So they're quite sort of binary cut-offs there. But actually, when you look at the data that's out there, so this is from a previous study that we did as a meta-analysis, systematic review, looking at what is the volume outcome evidence for revision knee replacement, and actually the evidence is quite scarce. There's a very limited number of papers published in literature, and within those papers, actually there's a high degree of risk of bias, and that's for a number of reasons. The complexity of revision knee replacement, what's called a revision knee, the multiplicity of revision, all affecting outcomes. We looked at a number of outcome measures and found again a very low degree of certainty accepting their conclusions. So, and akin to all this is without data, you're just another person with an opinion. So what we set out to do is, using the NJR, is to investigate this. But before we did that, is that bearing in mind the high degree of risk of bias, a lot of this comes from population heterogeneity. So it's really important that we're not comparing apples and oranges. We're focusing on one specific cohort within that revision knee replacement umbrella, in order to make meaningful conclusions or draw meaningful conclusions from the results. So we know from previous work done from Prof Whitehouse's team, with each subsequent re-revision, your chances of re-revising that goes up, and indication for revision from the work from Oxford and Shiraz Sabar found that obviously indication for revision plays an important part in their outcomes. So we wanted to focus on what is the volume outcome relationship, is there an association between hospital caseload and outcomes in first-time single-stage revision for infection. The way that we did this is we used the MGR data, so we looked at all patients undergoing revision knee replacement between 2009 and 2019. And our primary outcome was re-revision rate at 2 years, and the reason we focused on that is that we thought that was more likely to be representative of the quality of the surgery that was given, rather than focusing on more delayed outcomes, such as later outcomes, which would then have bias in terms of re-revision for hematological spread of infection and because of implant-related factors. So we thought 2 years was actually quite a reasonable focus. And then secondary outcomes, we looked at mortality, chances of medical complications, prolonged hospital length of stay, and problems that were available to us. Probably can't see this very well, but essentially we looked at all the data we had available to us from the NJR through the University of Oxford. So from going back as far as 2003, we had about 95,000 revisions recorded on that. And once you really narrowed down to what we were looking at, we ended up with 1,500 single-stage first-time revisions for infection. And what we did is we looked at the exposure, which was the hospital caseload, and the way that we did this is we looked at, for each case performed by that particular unit, we looked at the number of cases they did in the previous 365 days, and we calculated that based on all of the revisions they did. So we didn't just focus on their experience in single-stage revision for infection, we focused on, before we applied that exclusion criteria, so we focused on the number of re-revisions they did, the number of days they did, and so on and so forth, so to get a more of a better understanding of their surgical experience and how their caseload. We adjusted for the following covariates. These are known patient factors, so patient factors such as age, gender, ASA, and we also adjusted for annual surgeon volume. We looked at hospital factors, whether it was NHS or independent, and then we looked at the year of surgery. What we then did, we grouped these together. So we looked at the mean annual volume per hospital, and we used regression modelling. And we also found that there were some non-linear relationships within the data. So we modelled for this using a technique called restricted cubic splines. But essentially, we did a multiple logistic fixed effects regression model. The demographics were broadly similar between the groups. If you were to categorise hospital volume into four groups, they had a roughly similar in terms of their ASA, patient profile, and age. Looking at the data, roughly 50% of all revisions that we found, so all first-time revisions for infection, were performed by units with a mean annual volume of less than 30. And then when it comes to the sort of hard outcome data, this is our primary outcomes. This looks at re-revision at 2 years. On the x-axis, you've got the mean annual unit volume. You can see this relationship, whereas if you're a higher volume unit, the chance of re-revision within 2 years, or probability of re-revision reduces over time, over that period. What does this mean clinically? So if you were to categorise this into a bit more meaningful results, well, if you're a unit performing more than one revision a week, using that as a reference, and if you were a unit performing less than one a month, then you can see there's a 2.53 higher odds of re-revision in those low volume units. We looked at secondary outcomes, so medical complications, 90 days, mortality, length of stay. There's no obvious differences. And we didn't include PROMs, so there were only 5% completed PROMs with pre-op and post. So this shows that there is an association with more experienced units. They typically have the lowest re-revision rates. As I mentioned, the odds is about 153% more than if you compare lowest volume to higher volume units. What this means, it may suggest, again this is by association not causation, but it may suggest that the team's more familiar with the management of PJI and more associated with better outcomes. There are some limitations, as we talked about,